Good afternoon to all. As Senior said, today we are going to learn about ostomy care. You might have seen different types of ostomies in your settings. You have to understand that different the types of the problems and the management will be different for each ostomies and each different person. And today we have Dr. Mr. Immaraju Swarup. He is a MSc nurse and also he is working as a palliative care nurse. Now he is a nurse trainer in implementing palliative care units in state of Telangana, and he is currently working as a nursing superintendent for Kumudini Hospice, Kumudini Devi Hospice in Hyderabad under Pain Relief and Palliative Care Society Hyderabad. And also he is working in neonatal palliative care department in Nilofir Hospital, Hyderabad. So he is having more than 15 years of experience in palliative care. He is the well-versed person in this field. Welcome, Swarup, and over to you.
Yeah, thank you. Thank you, Shiva. Thank you so much. Okay, so as said earlier, my name is Swarup and I'm a nurse working in the Department of Palliative Care. I've trained mostly to say nearly 250 to 300 nurses who were interested in joining palliative care. So a lot of experiences going on in my career of nursing. So right now I've been working in 3 different programs, like one in the pediatric home care, as well as a neonatology department in one of the government hospital in state of Telangana. And also we have the adult palliative care unit where I'm the in charge for that, and also taking care of all the palliative care units all over the state of Telangana. It's very nice to see you all here. Very good afternoon to you. I hope this session is going to give you a little bit of information, because I can't say that the whole this 1 hour is going to give you a lot of information, but there are a few things which can really connect you. So let us go into that. So Shiva, can I share the screen from my side, or what do you think?
You can.
Yeah, I'll do that. You want to do it?
No, you can.
Oh, thank you. So yeah, I hope everybody's able to see this. So is it visible for everyone?
Yes, sir. Please go for
fine, that's
the
fine.
slide sharing.
Yeah, getting it. Just give me a minute, please. Okay, fine. So here we are today to learn about the care of the patients who have undergone this colostomy. Well, I'm going to add some more little bit of my experiences in palliative care into this, even with the theoretical and practical exposure what we have seen. Like many of our nurses who came for the first time to palliative care doesn't really know exactly about what kind of plan or the goal do we have for the patients who have undergone this colostomy. So first of all, I would like to start with my session with a little bit of information about what it is exactly. We all know that the ostomy is nothing but an artificial opening. So it has derived from the Greek word. It means that a mouth or the mouth like an opening. So in which we have 2 types of ostomies. Number 1 is about the input ostomy, which means that when there is a obstruction and you just have to just open it, so that the input ostomies is nothing but the tracheostomy, gastrostomy, and feeding digenostomy. This is given in a different criteria, and the output ostomies are the material which is coming out of the body, with which we can do it as the output ostomies, which is nothing but the colostomy, urostomy, and ileostomies. This is a brief information about what exactly the ostomy is all about. So the pre-operative counseling. Before I talk about the pre-operative counseling, I would like to give you an example. There is a patient who is supposed to undergo the tracheostomy, not the colostomy. For example, we'll think about the intestinal obstructions. It's a complete intestinal obstruction. The patient's performance is doing well. So all of a sudden, the patient was referred to palliative care. Like we all heard about the palliative care. So it is all about making the patient comfortable and understanding the family issues and the current needs of the patient and the family. So as of when we go through that, the patient was referred to us before the surgery. there is an option of surgery, like opening the colon, which is nothing but the colostomy. For that, the patient has to be prepared, and also the family has to be. So I can give you an example of one of our patient who is supposed to go through this process, and at last, this patient hasn't got any kind of information about how the colostomy is going to be. So he only had a bit of information about how it looks like. So he's scared of how the future is going to be. So when he thought about that, he stopped for this procedure at all completely. So his death was very worst to say. Like he had a complete intestinal obstruction where he had a lot of vomitings, and slowly it has been generated to the fecal vomitings. Lot of vomitings. He became very fragile. He couldn't eat anything. The family was in a worst stage to understand his conditions. So there are a lot of things which undergo before the procedure even. So there should be a pre-operative counseling with which the palliative care can really come and help them. Not just about the post-operative care which we provide for colostomy, but still there are some situations where you have to prepare the patient and family. For that, you need a good teamwork. So teamwork is nothing but it is not just a surgical oncologist or the derived people who are there talking more about this, but still there should be some kind of questions or some kind of thoughts which the patient and the family may experience. Oh, maybe in my future, if I go undergo this colostomy, the patient may feel that I can't do my routine works. I don't want that kind of surgery to happen. I don't like the bags flowing on my body, and there are a lot of leakages from that. I really don't like to go undergo through this. But somewhere that patient has gone up to the level where he was out of the situation and he was out of the hospital for a long time, and he suffered a lot, and maybe in the last moment of his life he came back to a palliative care to have a good quality improved care. But that is not the situation where we can really deal with that. So the teamwork is more important. When there is an oncologist who is referring this patient to the palliative care, you may have to think about what are the current needs of the patient, what understanding do the patient have about this condition. So it involves the teamwork, like the doctor. Sometimes the patient or the family members might not expose to the doctor directly, because many of our patients and the families are more tensed to talk to the doctor, scared of talking to them. So maybe in that situations, the nurses can handle that situation, nor the counselors also take that particular specific role in counseling the patient and telling them that this is going to be advantageous for you. You can live long with that, unless you will suffer a lot with this. So maybe in that situations, a teamwork helps in that. Sometimes even I see a lot of informations are not shared to the doctor, not to the nurse, nor the counselor. But sometimes the housekeeping team takes that charge, and the families or the patient goes up to the housekeeping team and tell them that share their information to them. So which is very important. So we try to call up all our people together. So this patient had a plan of colostomy, so he's not agreeing. Do you have any ideas to put into this? So people come forward. Even the volunteers role is also much more in there, where they speak to the patient and family and tell them about the advantages of going through this. So it's a very good thing that when you involve all your team members into this, not everyone, like I said before, and it is all individual care. So you can't compare to the other patient of what is happening and how the situations are going to be. You have to talk to them in individualized care, how it is going to be in your future. And very good explanation. Sometimes we use maybe the pictures, we share some pictures from the Google. Many of our patients do that many times. They just go to the Google and search it for, and they get the information. They feel that, okay, this is what it is. So I don't want this to happen, nor they may accept for that. So a clear explanation which involves the good and bad which is happening with that. So how do you have to change your lifestyle into this process. Only then you'll feel more comfortable, and this will be helpful for you. And the emotional support, which is very important about how the future is going to be. How do I cope up with my family? How do I really have a good relation continued with my family members? So how do the people think about the society? So many times people may feel that it's just disgusting. It is not so easy for the patient who is having the colostomy bag opening just like that and going out into the society. So that kind of support has to be given to that, and also tell the patient that this is a place where you have to where the opening is going to be, and you have to place it in this way. Some kind of practical exposure could really try to convince the patient to undergo this kind of ostomies. And next is the preparing the patient and family for the colostomy. So when you try to prepare the patient and family, it makes your work more easier, because when it is in a stage where there are few things which can be done, You have to consider that. And unless if you don't talk to them or explore the issues what the patient and family is having, there is no point of going further for that, because the patient will suffer surely, and the death is going to be more worst than what they expected of. So when the situation comes, many times it happens. So to prevent that, you should have a good plan of action, and your goal should be in preparing the patient and family as a first step of action. Next is, there are a few common problems what I have mentioned in this. I'm going to talk more about that in detail in next few slides. So number one is about, many patients are more worried about the excoriation of the skin. So when you try to keep changing the bags more frequently, the patients may develop the skin damage around this colostomy site, which makes more worse for them, and they couldn't go for this kind of sticky bags again and again. I'm going to share that with you. Don't worry about that. And foul smell. So this kind of foul smell is most common for the patients who are in the bag, and we don't know when the stool is coming out of the colostomy, because it doesn't have any control over there, and sometimes it gets leaked. And just because of these simple common problems, the patient may feel that it is a bit disgusting. And some way you have to tell them in a way that they understand how it is going to be and how to secure that. And fistulas is also not most common, I can say. And there are fistulas happening when there is a multiple spread of the disease locally over the abdomen. You see a lot of openings everywhere over the abdomen, and there is a small amount of a stool leaking from that. And sometimes even bleeding has also been specified. I've mentioned it just to say that, okay, even this is also one of a problem. Whenever you see a patient with the colostomy who has undergone the colostomy, you have to look into all these problems before you start having an action plan of management. And some psychological problems, as I told you before, and patients might be little stressed about that and feel disgust, and they may get isolated from the family nor the society, just because of this reason that they have this colostomy opening up here. So you have to elevate all these problems. So what we try to do in our palliative care units, even in the adult wards, you see a lot of patients with the colostomy, even in the kids too sometimes. So this kind of preparation is more important, where telling them that, okay, this is how your lifestyle is going to be modified maybe in the future. You have to get adjusted to that, like the colostomy, nor the wound, nor the lymphedema, or any kind of such tracheostomy even. So these all things really, when you start talking to them, and these are the problems you may face, but we are there to help you. When you give such kind of support to the patient and the family, sometimes there is a chance of convincing the patient, and acceptance of getting that colostomy done, and the future is going to be more comfortable comparatively. And during the assessment of a stoma, before I talk about the assessment of stoma, as I told you before, it's important for you to look into these kind of common problems. So have a good care plan. So what kind of care plan? What is my goal of action for this patient to be done? So there is a patient who is active, alert, and oriented. Like I can say that the performance of the patient is somewhere around 50. Assume that. So in that situation, this patient need to have a very good care of action. So if that is how the situation is going to be, your assessment bases on, because the nurses plays a major role in all the palliative care centers, what I have seen. Even I have trained all my nurses who are in the district level programs. They work with the government hospital. There will be a lot of referrals with the colostomy and some other problems too. So in that situation, the nurse plays a major role in anticipating the situations, number one. Number two, having a good care plan of action. So when you have a good care plan, the whole team, like I told you before, the teamwork. So whole team understands about the patient's condition and what are my expectations and what are my goals for this patient in the given time of their work. So during that time, you have to take a little bit of assessment of how does it look for the first time when you see. This is called as an initial assessment. So when you see the colostomy and how does it look like? So like I mentioned in the first point there, as the color of the stoma, it should look cherry red in color, which means that it is very good and hygienic. It is clean. So look for the bleeding even. And edema around the stoma also has to be seen. So these are the basic things what you have to look for. And then your goal of action may change initially. And when the days pass on, there are a few things which you have to look into. And the herniation is also one of a problem. We look for the herniation and prolapse of the stoma. Sometimes you see the stomas, the opening is more prolapse sometimes, or it is retracted even. There is somebody's phone which is unmuted. Please try to mute that, please. So it will be distracting for the others. So try to understand. Okay, thank you. So there are stomas which are prolapsed. So the opening of the colostomy is more protruded, which means that it will be hanging around from the abdomen. So which looks very uneasy for the patient sometimes. So there should be a plan of action in a different way, not like the normal patients we do. And sometimes it is also having a retraction where the opening will be just very close to the skin, and you couldn't even see that. And next comes about the stenosis. Just a minute.
Swarup,
Okay. Yeah. I've unmuted. I muted it. I don't know.
Oh, okay.
So look for the stenosis and look for the peristomial skin condition. Going for the next slide, the skin care. Assume that we are not here to do everything in palliative care. We are not going to do the surgery. We are not going to prepare everything for that. But somewhere there is a role of the palliative care team involvement in taking care of the patient who has undergone the colostomy. Like I told you before, there should be a pre-operative counseling that even involves in palliative care. Followed by that, when there is a patient with the colostomy, for the first time when you are looking into that colostomy, have a good assessment. When you have a good assessment, it's easy for you to have a plan of action. Sometimes people will really have a very good assessment format. Most of our nurses do it very well, but they don't have a good care plan. It doesn't end with the care plan, but also continues with the follow-up of how the condition is. It's easy for us to manage a lot of our patients in the hospital setup. When the patient is admitted, you do it in your best way to control their problems and improve the quality care. But how do the patient and family cope up with that situations? And how do you think the patient and family manage that colostomy once they go back home? Like you see in our hospital setup, we have patients who are coming out from the government hospitals. A lot of patients come to us from a poor and very poor status, which means that patients really doesn't have money to eat. Do you think these patients learn more about that? Not at all. Do you think they have the exposure about the colostomy and the care of that? Not at all. Because we see a lot of patients who are well educated coming to us just for the colostomy care. Well educated patients come to us only for the lymphedema care. So palliative care is something beyond what we have learned, but it is all about talking more to the patient and the family, exploring their issues and trying to manage that symptoms and improve the good quality care. So you should be in palliative care. You should have all the aspects what I spoke to you before, like the good assessment gives you good information, followed by the good management plan and the team discussion about what is happening to him, and also about the follow-up care. How do you think the family can really understand? So sometimes we call up those patient and the family members to our hospital as a respite care sometimes, nor these patients are called up to our center only for the health education about the colostomy, which makes some sense for the family members to understand and how to change the bags many times more frequently, and what are the criteria measures to be taken. So what are the things and do's and don'ts for such patients who have undergone colostomy? It's very important. Unless you don't teach to the family, only if there is a teamwork happening there, and once the patient goes back home, and we provide home care services too. So we re-evaluate the situations. What was taught to you in the hospice setup? So they may come out with little bit of information. Sometimes you give a clear information to the family and they don't understand it. So try to understand or explain them in a way that the family and the patient really can understand, because try to add only the simple measures which can be done at home, not everything at all. So these are the basic things what we teach the family, not just teaching the family orally, but there are some situations where we write it in our own language to them, and these are the criteria or these are the protocol what you have to do every day in the morning. You have to do all these things. So from that I have added few points to this. Wash it with the soap and water at home settings. This is enough for that. Make it clean and dry. So the colostomy or the surrounding should not be wet all the time. So once it is wet, the sticky bags which are being connected to this colostomy will not be so sufficient, or it may not stick to that particular area well. So clean it well, make it dry. So when you just relieve the pressure for a while, there would be no skin excoriations happening around. and try to use the correct sized bags. Sometimes people may use different kind of bags with the different sizes. So I'm going to share that slide with you later on. So try to use a correct sized bags with which the protrusion or the colostomy, the opening, is connected to that particular site. So the stool which is collected from the opening is directly coming in contact with the bag. Instead, sometimes we see a lot of leakages, or the stool is collecting there or being in contact with the skin, which makes the bags do not stay longer. So you have to teach them, and sometimes even emptying the bag when this is 3/4 full. So when this is 3/4 full, try to open it from the lower end. So wash it well and leave it open for a while, and then pack it well. Lock it again. So you can just unlock it anytime when there is a the collection of the stool in the bag. So use some soft cotton material to clean this. Maybe it makes sense for us because many times when the people who are well educated, nor the medical professionals who are well educated or know more about this, it's easy for them to understand this. But my point of view is, it is not about our own sake, but somewhere it is important for us to teach to the family, and it is important for the family to understand what it is. Unless you don't do that, maybe in many of our hospitals I have seen patients who are referred to us, I try to take some information about what were taught for you in your hospital, in a private hospitals, because a lot of our corporate hospitals are built up a commercial way, where they take care of such patients only when the patient is admitted. Once they go home, they don't have any clue of what to do. Many times we see such patients coming up to us with a very bad wound. They don't know what to do, but they were from the one of the biggest hospital in the city. But what did really happen to them? It is all about less education provided to the family, less protocols or less information shared to the family, and they are not at all, they don't have any clue to go further and do those dressings, nor even the colostomy changing, nor the lymphedema or the tracheostomy too. One more point I would like to add here is, just after the surgery, any kind of surgery, think about the tracheostomy, think about the colostomy, even after the post mastectomy. Sometimes it will be more comfortable, very easy and easy to manage. But when the days pass on, you see a lot of infections from the tracheostomy. Infections even from some kind of fungal infections develops from the colostomy side, and some kind of lymphedemas we have seen. So it's important for the people who are treating them in the initial stages itself, when they talk more about or educate or motivate the family and the patient in a way to take care at home. It's important. It plays a major role. I see that, because we are not the people staying back with the patient all the day long and for more time, for the given time for the patient, how long ever he lives. But it is important for the family members to see. That's the reason why the government of Telangana has taken the initiative in teaching the family members, educating the family members in doing the good wound care. Like many patients and the families, they're doing it on their own, which means that we are not the people who really can touch them all the day. So it's important for the family members. So the government of Telangana has taken that kind of education role in teaching the family about, okay, this is your roles to be done at home. Sometimes we are there to support you, but it's important for you to learn more about that. Unless you don't teach them, they'll be avoiding the situations and they just go out and sit. Once the situation comes, it is very hard for them. So one of our center in the state, which is very close to us, named Andhra Pradesh. So there was one center where they just started it very early after the training of our nurses. I have seen a patient there. I just went there to motivate our nurses and the doctors in in caring of our patients and to see how the situations are going on. So when I saw there was a patient with the colostomy waiting for the colostomy experts to come out from some other centers, they just come on call. They do whatever the patients want, and they just collect the money and go. When I saw that situation, I felt very disgusting, because we have been teaching many of our nurses and the doctors in taking care of the colostomy. And after they're starting a palliative care unit, they're trying to call people from somebody else. They just come in, spend some 2,000 rupees for that. Okay, for the time being, it is all over. And they are completely dependable. Do you think the same thing happens when they go back home? And financially, to say they're getting money from somebody and giving it to those people who came there, like the colostomy experts, I can say. So if it is taught to the family, if the bags or the material which is given to the family, don't you think they can just do it on their own? It is not a very big deal to say. So there is a chance where I thought that, okay, we have to take that initiative and the nurses have to learn it well, give a good education. Because the people who came from the organization, they just charge and they don't teach anything. They change the bags and then they just leave. So it's very hard for them. So the nurses who are in palliative care has to take that initiative in taking care of that. So from which I'm coming back to this point now, skincare, use a soft cotton material to clean the surroundings and the colostomy. Never try to use any kind of powders or creams unless it is needed, because that itself makes the surface more drier. So sometimes the fungal infections may also occur at that time. Try to add some powders for a few days and it'll be all right, and then you can stop it. Like I told you before, there would be the skin excoriation happening, and there is the product named Caraya powder, the extract from one of the gum acacia. I'll share that pictures with you. Somebody would like to take that screenshots, that's fine even. And it also has the numbers too. So with the combination of the egg white application, I'll talk more about that in the later slides. So this talking about the skin excoriation, few years ago, I have been to Canada where I have seen, I was there in adult and pediatric hospices there to see how the things are going on and what are the things we can implement there. There were few patients with the colostomy. None of them have this kind of excoriation. Why do you think it really did not happen to them is just because of the family and the patient were taught. The patient was taught about how to take care of the colostomy at home. How do I prevent the skin excoriation? So how do I leave it open for a while? So many times we see our patients, they just pull it up and don't even wait for a while and they just replace the bag in that particular area. So prolonged pressure or the contact in that surface, which leads to skin excoriation. There is nothing big deal in that. The prolonged pressure and there is no ventilation to that, and the skin gets damaged, fragile very soon, and slowly the skin cracks well and drying, and slowly the skin get excoriated, and the other day you couldn't even put the sticky bags again. So sometimes the situation happens. So I haven't seen such situations in the other countries. It is all just because of the nurses have taken the lead in caring the patient with the colostomy. Lot of education they provide, the handouts and the brochures about how to take care, what are the benefits of taking care of your skin, benefits of taking care of your colostomy opening. There are such a lot of things. Try to initiate that situations, and it will really bring a lot of changes in the patient and the families. So this is one of a bag which I would like to share. These bags are available in our government sector and also in the private sector. There are a lot of bags available here. First I will talk about the advantages and then I'll go about the disadvantages in that. So this is a bag which is not transparent. That is a good advantage thing. Like there is a good opening. Maybe on the right hand side of your screen, you can see there is a measuring circumferences in that. There are a little bit of inches from the over end, top end to the bottom end, where the of the circumference is also mentioned. Only thing is, you just have to measure the opening of the colostomy and cut it into the circular area and then stick this bags. There is a layer over the top end which showing the arrow mark there or the red mark there, which means that you just have to pull it and stick it directly to the opening of the colostomy. Hang it down, and lower end, there is a very good locking system for this. You have to have a 2 to 3 foldings, and there is a sticker which sticks to this, and you can just lock it well. You can lock it, unlock it whenever you wanted to open that from the lower end of the bag. So it is transparent, it sticks well to the body, and it is nothing but sticky bag. The code number of that, the barcode number of that 17501. These are the bags which are given in our government hospital for free of cost. Okay, I'll talk about the disadvantages with that. One thing is, it is a little bit expensive. Maybe it may cost around some 200 to 300 rupees per bag. Maybe it doesn't make sense for the people who are in the hospital, maybe not for us, but it is very important for the family members because there are only 2 bags provided from the government sector. This bag can be useful only for very short period of time, maybe 6 days, not more than that. So when you fix a bag on the 6th or 7th day, you may have to remove it and take another bag. Assume that for a month, how many do they need? Maybe approximately 4 bags they might need. And sometimes it get disconnected due to some other reasons. They have to change it again. Assume that 4 bags per month, 3, 4, somewhere around some 1500 to 2000 rupees they may have to spend for the bags itself. It is just about the bag to buy those. And how about all the medications which they need to? And when you talk about the patients who are poor and very poor, poor in the sense they have money to eat, and the patient, this kind of financial status, that's okay for them. They may just borrow money from somebody and get that for a while. And how about the patients who are very poor? Very poor in the sense they don't have money even to eat. Do you think they can buy this? This is what my question is. So when there are patients who are well off, you don't need to talk more about that. They can just buy and it's easy for them. So try to look into the resources which are available for the patient and family. Look into their financial status. Look into their society. So when you just think about all these things, it makes your work more easier. Unless you teach them in a well-educated manner, they don't get anything into the mind and they just leave it open. There is a patient, for example, with a fentanyl patch put on, and there was a very poor education about how to change the patches. He put the patch on his left side of the upper chest. He went out to the washroom, had a bath, and came back, and it got disconnected on the second day. He put another patch. So, aren't we wasting that resources? It will be more helpful for the others, even. So, think about it. Sometimes there is a lag where even the hospital could not provide this kind of colostomy bags. Earlier, few months ago, for more than 3 months, there was no bags given for any patients. They just have to depend on the medical stores where they charge a lot for that, and it's very uneasy or unexplainable. Even some situations where the family can't buy those things, and there are a bit of disadvantages even to that. The other disadvantage I would like to share is these are the sticky bags, which means that prolonged sticking to that area and you don't leave it open for a while. If the family is not educated about that, they just remove this old one and place the new one on the surface, so with which the skin excoriations may happen. Sometimes it get leaked even. So this is a bag where it is having the good advantages, even good locking system, and it is not transparent. The stool which is collected into that is not so visible in that. I'll share some more pictures in this. Have a look at the two different bags, which is also available in our centers. The one on the right side of your screen is a um, very simple. It's a transparent. It doesn't have a very good sticking process even, and it has a very good unhappy unlocking system there. So I don't think it can be used for a long time. It's very cheaper to say like 80 rupees to 90 rupees, you can get one bag. But still, there are some psychosocial issues, or the patient may feel disgusting looking into that every day. He loses hope just because of that. Just have it in mind. Most of our patients who are undergoing such kind of procedures, either the tracheostomy, nor the huge wound, nor the lymphedema, nor the colostomy, all these peoples, all these people may not die just because of the cancer. There are some psychosocial issues which are making them more unhappy, unsatisfied with their life, and they feel that what is the point of me living like the situations. So when you think about this, and also the financial impact will also be there, getting isolated from the family, or they themselves come out of the house and live in an area where they don't have any resources available. They are really in need of palliative care at that time. It's important for you to think about it and go and try to do what using our resources to that patient. On the left hand side of your screen, there are some different bags which have a polythene bag, which is so strong. The polythene which used in that is very strong. That is from the company named Ostomy India. They provide a good quality bags. The one advantages I'll talk about this is it doesn't have a stickiness. These are the bags which are used with using the belt. You can just fix the buckles on the both sides of the opening. You can see small openings on the other end, both ends of the colostomy bag, and you just have to fix it around your waist and leave it open. Over the lower end, there is no locking system. Only thing is, they haven't provided. I feel that they haven't provided any locking system for this. Is to provide a good quality. It has to live long for this patient, because these kind of bags can be reused again and again. Once it is filled with the locking system at the lower end, you just have to tie it up in the lower end. So once it is filled, you just have to just open the bag and remove this belt from the buckle, leave it open, wash it well, make it dry. If the patient buy 2 bags and 1 belt, that is much enough for them. It may remain for more than 4 to 6 months when you use it in a proper way. they don't need to go for this kind of sticky bags anymore. There are some disadvantages. What I see in that is the patients who really have a protrusion colostomy, not the retracted colostomy, might not be fit enough for this, because when there is a leakage, there will be a lot of chances of stool coming out, not into the bag. Maybe there will be a lot of leakage from the other ends of the opening. So that is one disadvantages I see in that. And the other disadvantage from this is uh, the other disadvantage is it is a transparent material where the stool which is collected into that is more visible. So these are the few things what I can say, but it is very cheaper to say, like for more than 150 rupees or 200, it can be provided for, sometimes even provided for free of cost to the patients. We purchase this from the company named Ostomy India, and we teach the family and we tell them about the benefits of using these kind of reusable bags, nor they can go back anytime if they don't want with the sticky bags, where there are a bit of disadvantages and a little bit of technology is also added into that. And these bags also have a small carbon plate into them, which absorbs the bad odor. Like where earlier we discussed about the foul smell. So it has a bit of technology into that too, but it doesn't have. But some way the patients are getting adjusted to that. These are the best bags I can say. The reusable bags could also be helpful. So this is also one of the different bags which we can use it. It has a very good clamping system, and it also sticks to that surface, and it also has a very good circumferences, and it is not visible. Maybe in this picture you can see the front and back side of the opening, the colostomy bag. So which the stool collected into that is not so visible. Sometimes if the patient feels very ugly and they don't like that to happen, you can even specifically tell them to purchase these bags. So this is how the colostomy looks like. There will be an opening where the stool is collected from the intestine, large intestine, and without any control, the stool will be collected directly into the bag. The patients with this kind of situation, they can live long when there is a good, comfortable quality care. The improved quality care is provided from the palliative care. Unless you don't do that, just because of the infections, just because of the psychosocial impact on the patient about what's the point of me living like this. If that is how the situation, maybe the patients might not have a good quality, and the end is going to be more worse. So just have a thought about how to take care of this. And this is a cherry red in color, which means that the opening or the colostomy is really looking good. And you can observe for some kind of assessment. The color of the colostomy is cherry red in color. That's fine. How about the surroundings are doing on? So the prolonged pressure applied on the surface or the surroundings of the colostomy, which makes the area more burst. Prolonged pressure applied, you can see the redness around the colostomy, which means that, and even the skin is more shiny, which means that it is losing its elasticity and losing its the blood circulation to that particular area. Slowly there would be a more of excretion around this, and the patients cannot use this kind of sticky bags anymore when there is a lot of excoriation happening there. So how do we really deal with such situations? And before that, I would like to add some nursing issues to the situation in this condition. What are the things what the nurses has to look into? We have to understand there would be the irregular bowel action, which has to be specifically mentioned and informed to the patient and family that this stool will not be under control. Your regular pattern of passing stool or the defecation is different from how it is going to be in your future. When you tell the family and patient about it is what's going to happen, they'll just think about, they'll understand about that. Point number two is sometimes even the patients may get constipated even there is a colostomy. We all know that colostomy doesn't carry the hard stool like we regularly get from the rectum through the anus. But somewhere there is a little bit of stool as well as the water mixed up through that, so there will be a good passage. But even the patients get constipated just because of the changes happening in the body, and they get constipated. Nor any kind of opioids or any other antidepressants can also lead to the constipation. So don't just take it easy. It's important for you to assess and understand this issue also has to be brought up to your physician and plan for the action. Like constipation, there is a colostomy. Only thing you have to do is insert your little finger into the colostomy, observe for the any kind of hard impact in the opening. So if there is a hard impact in that, try to remove it by your little finger, not the index finger. Little finger has to be used for that. So try to give enema even through that. Sometimes even suppositories also can be given through that. So with which the stool gets more softer and the stool can be passed through the colostomy. Sometimes the patients may develop diarrhea just because of that. It would be the cause would be the infections where when there is a change of the foods happening, we'll talk about that in the next slide. Sometimes the patients may experience diarrhea. So try to increase the intake of fluid and hospitalize as early as possible. So we may have to stop the medications which is making him more worse in that situation. Nor is there anything else which is making him more diarrheas. So that is what you have to see. Flatulence, generally, these are the things which people never discuss about. So it's important for you to look for flatulence even. So don't just hide those information, try to explore that to the patient and you'll get a lot of information. If your assessment is good enough, it's easy for you to manage the situations. If your management is very good, you can easily follow up the situation. So try to think about having good assessment scales for your patients. So the dietary advisors are eat regularly, do not skip the meal. So it is a change of pattern, the habitual changes for the patients for the rest of their life. Eat regularly, do not skip the meal. You have to eat food in time. How much ever the patient is comfortable to eat, so encourage them to go for. When adding new foods to the diet, try to add a little bit with other foods. So don't just give them the foods which are not so easy for them to get digested in. So the third point, what I would like to mention for all our patients we are dealing with is, try to provide a small meal, frequent meal. The meal should be best chewed thoroughly. Limited amount of food which is given entered into the stomach will get digested easily, and they don't feel that, oh, I am being fed a lot. Most of our patients with these kind of situations, they lose their appetite. We all know that the anorexia is most common in most of our patients, which will be followed into the cachexia, which means the losing the weight. They just see their body, their disfigurement, which itself makes their hope lost. It's a little bit of food, which should not be disgusting for the patient. Very little bit of food, which the foods are liked by the patient, and try to make it more frequently, so that there will be no impact in that. So limit foods containing sugar, as it may aggravate diarrhea. No spicy foods to be given to them, and the high fiber diet, which helps in a good hydration and helpful for the patient in managing their problem. 6 to 8 glasses of water every day, but not with the meal. So if possible, try to provide that. If that doesn't happen, just forget about it, because not all the time all the patients may take that. So it should be managed on your own choices. So how do you deal with the excoriation? So if you see any patient with the skin excoriations around, what are the plan of action you should have? Only one thing I can suggest at this particular point: when you see a patient with colostomy, try to take a picture from the patient. Take a consent of the patient that I need to take a picture. How is the picture going to help you in your future? That's what the question is. The pictures give you a lot of information in implementing your goals and evaluating your management strategies. For example, you take a picture for the first time. In your initial assessment, you have taken a picture. When the days pass on, slowly after receiving the patient has developed a skin excoriation around, which means that our care need to be improved. When you have a goal of action of initial assessment of this is what is happening, later on the days pass away, there was skin excoriation and the protrusion was very bad. There was a little bit of bleeding happening there. When such things happen, we have to accept the problem and agree that, okay, this is all the problem what we have faced, and maybe we may have to improve our own strategies in caring the patient with the colostomy. So again, the team sits together in discussing about where did we go wrong, what went wrong in caring the patient. So these are all depends on when you're having a good care plan. Care plan involves a good picture too. So using the carrier powder and egg white, it's nothing but the carrier powder is the product from the Ostomates India. We use it regularly. And this is a powder form from the extract named gum acacia. So this is a powder mixed with the egg white. We know that egg white is more sticky. So only the egg white, no, the yellowish thing has to be taken out. The egg white has to be poured into the bowl first thing, and little bit of sprinkling of the Caraya powder, what you have seen, has to be stirred well. So when you mix it together, there will be no crystals forming into that. When there are no crystals, which forms as a cream and as a paste. So the paste can be applied directly over this area. Just have a look at this. The surface where there is a excoriation, you can see the arrow marks where I'm mentioning the mixture of these two products. So I'll tell you wait. So only thing is you have to make the paste ready, apply it around the colostomy site, leave it open for 2 to 3 minutes. Over that, you have to place the sticky bags what you have. And beneath that layer, you have to take a polythene cover which has an opening of the surface, the colostomy site, and take a measurement and leave that place open and stick those polythene cover over this particular area. So the bags comes out in this way with the opening around the colostomy. The main idea of that is there is a skin layer with excoriation around this area with the cream of Caraya powder and egg white mixture over this area where we have applied it locally, and over that there is a layer of a polythene sheet which we have stick it directly to this. Over that you can just stick the colostomy bags to this. You might have a question of how does it get sticked directly to that? Don't you think the cream can get disconnected very soon? When you just leave it open, dry, it becomes harder very soon. It comes back to its normal stage when you apply a little bit of water to that. So like earlier we have seen, when those extracts were from the powder form and the egg white is a sticky part. When you mix it together, it forms as a very good layer, binding layer over the surface of the skin, and it helps in healing even. The egg white binds as a layer. The Caraya powder has a healing process where it is an Ayurvedic preparation, and there are a lot of good things happening with that. Even any kind of skin excoriation, the Caraya powder can be applied directly. And sometimes if you don't have the Caraya powder available, you can just add the egg white directly to that area and stick it well, and then you can just place it well. Or sometimes if there is a leakage found, try to put more dynaplasters around the surface from the excoriation. Beyond that level, you have to put on the dynaplasters. So for a time being, till the excoriation comes down, you're not applying pressure in that particular area. I hope this is making a little bit of sense to you. So this is a product where we have purchased it. We take this kind of material, like we have colostomy bags available and the irrigation bags and the ostomy products like the Caraya powder and also the Coloplast ointment. I'll talk about that in the next few slides. Okay, so how about the colonic irrigation? This is a question which raised for me a long time ago when I joined in palliative care. So till now we have seen the reusable bags and the sticky bags. And there are some double-barreled openings and the bags available, which are not being used regularly in our centers because of the availability or the resources more expensive. We're not going up for that because it really had more of excoriation comparatively with the sticky bags. So we don't go for that. And this is a very innovative process of taking care of the patient with the colonic irrigation. So establishing the main goal of the colonic irrigation is establishing a regular bowel habit. So it's nothing but the patients who get used to that, it's easy for them to get adjusted to the change in the bowel habits. Number two, it cleanses the colon from gases, mucus and fecus. So that helps in well and prevents the skin excoriation, because through this irrigation, you're not going to apply any kind of sticky bags to that particular area. You're not using any kind of reusable bags or using the belts even of the surroundings. It doesn't have it. I will show you in the next slide. So remove irritant foods ingested by the patient. Sometimes it is more helpful and easily drained up in a fixed time. So remember the last point I mentioned here, once the habit forms, it can be done in an alternate day basis. I'll practically just show you how it goes on. And so this kind of irrigation need to be continued lifelong. Tell the patient that It is not just for a few days. Like, the many of our bowel habits are different. Many times people defecate in a different processes. One goes out every day in a fixed time early in the morning for defecation. But how about the other people? They go it in different way, and some are been used to smoke during defecation. They chew tobacco during that. Sometimes people read newspapers during that time, and some are stimulated with the coffee or tea. There are ways of getting used to that. As the same, the bowels has to get used to that situations. To let that happen, it's important for you to teach more about that, and the patient has to get adjusted to that. If you don't do it well, the bowels will not be in a regular manner. So it will be all irregular again. There is no point of going for the irrigation again. So the irrigation need to be continued lifelong. Point number two, habit formation only happens after 20 days of your starting date. Whenever you see such patient with a good colostomy, I don't think this patient need any kind of sticky bags nor the reusable bags. It's important for him to go with the colonic irrigation. When that is how the situation, for next 21 days during the day one of your starting, it's important for you to tell the patient that every day it has to be done in a very fixed time. Assume that when you start doing it in a fixed time, the stool get collected in the same time. All the other time, the patient can be free of it. So in my career, for the first time when I gone up for the colostomy, I've gone for the home care. I have seen a patient with a very good activities, like his performance was 60. He's able to do his own works. He has a disease, a limited disease in his body and cancer, and some way he was fine. I felt that why can't we try this using this colonic irrigation? I told him that it may cost around some 700 rupees. He has purchased one bag and he started using it. It took really time for him. So the slides what we are mentioning here is not something from the research evidences at or the information from the Google. We haven't shared it. So once we learned more about this, we implemented it. We implemented and we saw the results from that. And this is what the research-based evidences. I'm just sharing that with you. When you tell the family that or the patient that it has to be done every day, and it at least takes 21 days time for the patient get habitual to that situation. It's important that irrigate daily at a fixed time. When you do it in a fixed time, the stool will be collected. It is not, I'm not talking about the day one and day two or the next few days. I'm talking about his future. Maybe after a week or 10 days, you can see the stool or the impact collecting over the colostomy, and you do this kind of irrigation that will really help the patient in improving the quality. They really doesn't need any kind of bags to be placed on his body, nor connecting any kind of sticky bags to that, nor he may not worry about going out into the society. He can just go out just like that, because once the bowels are evacuated, it takes again 12 to 24 hours for the stool to get collected into the intestine. Like for example, when you're trying to irrigate the bladder, when the urine has come out completely, and then there is nothing else to be done. You doesn't need any catheter again, which means that the bladder takes approximately 5 to 6 hours to get the urine get collected into that. As the same, the bowels also plays this kind of role where the large intestine is empty. It takes at least time for the stool to get collected into that. And I'm telling you again, it has to be a habitual formation. It doesn't happen in a day or two. So just have it in mind. So this is how the colostomy or the irrigation set looks like. So there is a bag. See on the left hand side top end of the screen, you see some kind of measuring scales which are mentioned in there. So that is 1500 ml of water has to be placed into that. So come down with the tubing there, and you see a regulator there, so which can lock the flow of the fluid into the intestine. And over the lower end of the left side of the screen, you see a funnel, a V-shaped, reverse V-shaped funnel, which has to be inserted directly into the colostomy. Before that, there is on the right side of the screen, you have a bag which has a buckles, and the opening of the bag has a two openings. So it is just like a pant style. One side there is an opening from the anterior end, and from the posterior end, it is just clean and just left it like that. So one opening where this bag has to be fixed up, and just try to follow my arrow marks here. So this is the opening, which has been connected like earlier I told you about the buckles here. These buckles get connected to this bag, and there is an opening here where this funnel, after filling the fluid into this, it has to be placed somewhere on the higher end. So with the gravity, the fluid will be collected directly. When you loosen this regulator, the fluid get collected and pushed out through the funnel here. So once you fix this bag, there is an opening here, and there is also an opening over the lower end of the bag, where this bag can be opened directly into a small bucket or a bowl, where the evacuated fluid or evacuated stool to be collected directly into this. There is an opening. This end goes down into this. So once you fix it, the funnel directly comes in contact from the top end, getting protruded into this, gets involved into this colostomy. It gets into this, and you have to release the funnel. So once it is open, the fluid which is collected in this, the whole fluid gets directly into the intestine, enters into the intestine, and washes out, cleanses out the whole intestine. And it may take some time for that to get evacuated through this bag. Once you've drained the fluid into the body, you can just remove this funnel, leave it open. The bag will remain for next 20 to 30 minutes. So in that particular point of time, the intestinal feces which are in the abdomen gets collected directly into the bag, drains down, and collects into the bucket or the bowl which have been kept into this. See, have a look at this picture. So there is a funnel directly entered into this, and the bag which is connected to the body, it's a transparent bag which goes down into the bowl, because the stool which is collected into the bag drains out in this way. And you have put a mineral water into this, directly entering through this tubing with the regulator open, and through this funnel it enters into the body, evacuates, and it directly, you just have to take it off, and the stool or the feces which are collected comes and collected directly into the bowl which are kept in the lower end of this. So that plays a major role. I feel like it is not so expensive. Only thing is the patient has to be taught more about that. Many of our patients doesn't have time to even think about it. Many times when my experience, when I speak about this kind of irrigation bags, they're a bit confused and they just leave it and go for the sticky bags again. So going back for the sticky bags is easy for them. Once they develop expiration, and the rest of their life is going to be more crucial. They can't use it, and more of infections, and they can't place the bags anymore again. So a lot of such things may happen. It's important for you to convince the patient and family about, you can just purchase this, that makes your work more lesser. You can just go around keeping just a pad. See, once everything is done here, there will be no stool coming out anymore. Once you have evacuated everything, you just have to place a bag here, place a soft cotton cloth over that area, and leave that just open. You need not worry more about that, because tomorrow at the same time the stool will get collected, and you have a process of doing it every day. So many times when you change the place, you're not adjusted to the foods what you eat, right? So this is all the routine process of ours. So once you get adjusted to the climate nor the foods what you eat, it's more easier for you. As the same, you have to get adjusted to the situations, unless it doesn't make any sense for you. The solutions most probably use is the plain water, sometimes the normal saline. Soap water enema is given only when there is a little bit of colostomy or hard impact into that. To remove or drain that, only we use it. And sometimes only in emergency, when the family doesn't have any kind of resources available, because we see a lot of our patients come from a very remote area where they don't even have the primary healthcare centers available. They only depend on either the local resources, like a very small doctor. They're not even the doctors to call up as. So they're just a practitioners where they give some kind of injections. When they are dependable on somebody, don't assume that it all can happen in a very short period of time. So it's important for you to think about that. So every time we discharge the patient with addressing their local resources, we call up to the doctors who are supportive to them, not the nurses or any kind of lab technician, whoever it is. We tell them that try to please help the patient when there are an emergencies. So we are there to support you. We'll teach you how to do. So there are such things happening many times. So we stay in the city limits, that's fine for us to go out and travel for the home care to help them. How about the patients who are traveling for more than 10 to 12 hours? There are few patients who travel a lot. They have to come to the city of Hyderabad from a very long distance. They live in a remote areas where there are very less number of houses. So in that situations, we talk to the local available resources or the person who is available there. So we convince them, we tell them that we are there to help you. So we try to teach the people, so that really will be more helpful for the family members to get relaxed. Even though they go home, there are people who can support them. So it's important. There are a few instructions which has to be given to the family, and even we have to learn it. Start irrigation 3 months after the surgery, not just after the surgery. Till the time being, you have to use the sticky bags, not the irrigation bag. Do not irrigate if there is diarrhea. So once if there is a diarrhea, if you try to irrigate, and the patient may sometimes even collapse just because of that, more dehydration may happen. So do not irrigate through the ileostomy, and do not irrigate for more than once daily. So once a day, that's okay. And habitual formation, as we spoke about before, it takes some time, so just keep it in mind. So 1.1 to 1 liter, 1.5 liters of water has to be used into the bag pouch, where that will be drained directly into that. Lubricate the funnel well before introducing into the colostomy. The colostomy opening is a very sensitive part, where small ruptures also may lead to a lot of bleeding even. So lubricate the funnel using a lignocaine gel, or sometimes the coconut oil can also help in that. So do not use force to introduce the funnel into that. So when you're forcefully introducing it, it may get ruptured, and there will be more of damaging and pain may develop to that. So clamp and remove tube from the stoma after running the fluid. Once the fluid is entering into the abdomen, you just have to remove this tubing. Wait for the time. Wait for the return flow. It may take at least 30 to 40 minutes. So the patient can sit somewhere in the washroom, not close to the washroom, and then he can just wait there and read the newspaper and do his own works. And the routines will be changed, but somewhere that makes more comfortable comparing to the other sticky bags, or going out into the society with the bag. It doesn't like, most of our patients doesn't like to travel handling those bags, because they're more tensed. If they're traveling in a bus, and assume that suddenly there is stool collected into the bag, and there was a little bit of leakage, how do you think the people will think about? There is a lot of bad smell, and the people may just throw the patient out of the bus sometimes, so, or ignore going out with him. So it is a little bit disgusting for a person, a human being, to think about it. So they may worry more about that, and they just stop going out anywhere for any kind of parties or functions happening in their families. So encourage them, motivate them well, and convince them to bring into the reality. Seek for the help when there is a continuous blood oozing from the opening, and when there is a prolapse or retraction or hernia, the colostomy experts has to come and have a care plan. When there is a colic pain lasting for more than 6 hours, which just means that there will be the upper intestinal obstructions or subacute intestinal obstructions may happen, or the local spread of the disease would also be the cause. To observe for the check for the cause, the patient has to brought up to the hospital. And when there is diarrhea, dehydration, constipation, and abdominal distension, seek for help from the doctors. So ileostomy not functioning for more than 24 hours, seek for help. And periosteal skin problems also has to be considered, has to be seen. The holistic approach or the care, we have all these discriminations mentioned before. These are the aspects where the patient feels more uncomfortable in. That's okay. Physically, I'm okay with that, but psychologically, I'm very upset having this kind of worry or tension about why am I suffering a lot. So spiritually, why is God punishing me in that way? What kind of curse did I do? I'm suffering a lot with these kind of things. This they haven't expected before. There was a patient with us who unexpectedly started having this fecal vomitings with the complete intestinal obstruction. You know what the patient thought? What was a fault from my side? I haven't done any kind of curse, nor I haven't hurted anybody in my life. Why did God give this to me? Because stool coming out from the mouth, he didn't expect it at all. He didn't even guess his life is going to be like that. But there are some situations where the palliative care unit can explore how the future or how the things are going to change. So it's nothing but having an anticipatory plan of action really makes a sense, and giving a little bit of information day by day to the family can bring you back to the situation where your information are been shared well and the family is bit relaxed. Unless you don't do that and you are relaxed today, tomorrow when there is such kind of questions arising again and again, it is not the correct time for you to deal about that. So what I say is, even the nurses have to take that role of talking to the patient. It's all about the communication. When you start talking to them, they build up a good relation with you. So sometimes they come out with the sexual aspects even. When I have a colostomy, can I have a sex with my wife? These are the not a simple things I can say, because none of our people, the patients can come forward and tell us about these things. Unless you don't have a good relation, it doesn't happen. So try to have a good relation. That relation can be built up well with the attention you provide to the patient, followed by the good plan of action and management and clear information to the patient and the family members. There are some phases where the patients experience. One is about the shock. They go up into the panic level where they don't talk to anyone. They feel that their life is not good at all, and sometimes they defend the situations and retreat, and they don't accept the situations. People don't acknowledge them, but it's important for the palliative care team to acknowledge them, and adaptation and resolutions also has to be seen. So some physical problems, like I mentioned before, I'll quickly go through this. A good skincare, try to manage the leakages. Like there will be leakages when there is a skin foldings around this. Like I told you before, the colostomy, Ostomates India is also providing a good cream, uh, which is soft once it is till the time it is exposed into the air. Once it is coming out of this, it becomes more harder. So during that period of time, it has to be placed around the colostomy and fix the bag directly to this, and there will be no leakages around it. So the stool will be get collected directly into this. And check for the bad odor, gases forming, and pain and fatigue. Change of the clothings more frequently. People may use the same cloths again and again. Tell them to wash it well, or just throw it up and take some new cloths. The fresh cloths makes the colostomy feel more fresh. Sleep disturbances. If I have the colostomy, can I turn up to the other side? If I have a colostomy, there will be a leakage even at night. What to do? So people doesn't sleep just because of. They try to care that. So it's important for you to highlight those points and talk to them. How to maintain a good nutrition, how to maintain a good exercises, and the changes of the lifestyle has to be explained from the palliative care aspect. And psychologically, patients may get more depressed about it. Anxiety, uncertainty also has to be seen, and lack of privacy, recurrence, fear of recurrence, and the negative thinking about the situations happening. They never think as positive. So it's very important for us to talk more about that. Isolate themselves, nor isolate from others even sometimes. And socially, preparation of the emergencies may happen. Sometimes the patients with the colostomy, they may develop parapheresis. Look for those signs. It is not just the colostomy is done, everything will be all right. Unless you don't provide a good care, the patient may experience a lot of such worst complaints and he'll be on the bed all the day. So look for the burning maturation many times, and the tenderness of the spine, and weakness of the lower limbs. These are the basic things for the patient with the colostomy, as they may develop the metastasis of the disease. How do they travel? How do they work? What are the social and public obligations do they have? Is there any stigma around in the society? And try to have the intimacy and sexuality, caregivers and the partner's relationship. How are you managing your relationship with your partner? These are the questions, and the financial management. These are the questions what we have to touch on. Spirituality, acknowledging the patient again, searching and applying for the meaning. And faith, do not take their faith out of it. Only thing is, we have to tell them that okay, you can just have your own faith. We hope you should be better, but somewhere I'm worried that if you don't do this, you're going to be in the worst situations. It's important. So these are the people who get involved in the patient whom to be taken care of with the colostomy. So the patient and family were seen or observed or supported by all the palliative care team members together. A little bit of information about the tracheostomy. So this is a permanent tracheostomy, where it has a inner cannula and it is a metal plate, inner cannula and outer cannula. Only thing is you have to secure that area. I have added this ostomy just opening just to show you that there will be a lot of skin excretion around the tracheostomy site. So to prevent that, it's important for you to take out the inner cannula, clean it well, place it in the betadine solution for a while and use running water to clear it. And if there is any blockage, use this obturator to clean the inner cannula, replace it. Use a fine thread around the neck to fix it well, so that there will be no any kind of excoriations even around the neck. Sometimes we see the cloth has been placed very tightly around the neck, with which there will be a rupture. So we can call it as a pressure application. More of pressure application in any part of a body may leads to more of damages. The other day they couldn't even tie it well. So you have to tell the family that these are the things what you have to take into consider for. And fine threading, like I told you before, maintain a good hygiene. Do not touch the tracheostomy all the time, more frequently, unless there is need. So during even touching that particular area, you have to wash your hands. The family, whoever is coming and being close to them, they have to take some kind of precautions. And the care of the inner cannula, like I told you before, care of excoriation, and the patient and family education also comes into this. Securing the site well. When even there is an excoriation around the tracheostomy, sometimes the egg white and carrier powder also plays a major role in that. One time when I saw the patient with the excoriation around the tracheostomy, he was brought up from one of the private hospital, a good hospital, but they haven't taught more about that. The patient one day was explained that your disease has spread again. There is nothing we can do. You can go home. As it is expensive for you to stay back in the hospital, you may have to spend lakhs of rupees into that. The patient was thrown out of the hospital, and they were told to go back to the government hospital where we have a palliative care unit there. This patient was referred from there to our hospice. And the patient came in. I took a small snap of this, and I had a care plan. I told or explained to my whole team, like the doctors, nurses, and the counselors, about this is how the situation is. My goal is to prevent the excoriation and improve that. The same patient, after a week period of time, went back to the same government hospital back for further management. The doctors were really surprised by seeing that. A week ago, he had a lot of excoriation. How come you have done it? I can say that when you have a good teamwork, you can do all these things in a proper way. So it's important for you to have a good teamwork and action plan ready for you. The take-home message is the acceptance of the stoma and social interaction, which is important for you to deal with that, and self-care efficacy and adjustment. The social interactions and the interpersonal relationships also has to be done well. I'm up with my slides today. Any questions? Please go ahead.
Thank you, Swarup, for the excellent presentation. If you have any questions, please ask him.
Yeah, any questions, please? So if there are no questions, which means that you understood everything about the colostomy, nothing entered into our mind. Some people are smiling. It means that it went into your mind. Thank you. Any questions, please go ahead.
Swarup, I have a video on colostomy care. I'll show that video. So 5 minutes video.
I'm sorry, I haven't got that video. It got hanged.
No, I have a video on colostomy.
You have it? Okay, please go ahead. Thank you.
Okay, thank you. Any questions? So, Swarup, yeah, on chat, you can some video. Okay, I'll try to make one video on preparation of karaya powder preparation. That.
Yeah. I'll do that, because last month we had another discussion where to teach to our staff and also a few people who came forward for the training. We have prepared a video, but that is not able to get edited in that. So that's the reason why I haven't shared, because we have already done it. So we'll see. Maybe next time then try to do it.
Okay. I think no more questions. Unfortunately, we didn't get the patient story today. So I will present. I'll show two case scenario. So just one of you can read that patient scenario and try to answer the questions. Can any of you please read this patient scenario? Who will read? Sharina? Please unmute yourself and read.
Ma'am,
Yes.
can I?
Yeah.
Mr. Raman is a 35-year-old gentleman. He was diagnosed that have carcinoma colon 2 months ago. He underwent proctocolectomy and ileostomy, followed by chemotherapy. He has now come to the OP accompanied by his wife with skin excoriation around the ostomy site. He looks tired, agitated, with poor skin turgor. His wife says after the surgery, he is angry and upset. What would have contributed to him developing skin excoriation? Why is he angry and upset?
I hope the case scenario is clear and two questions are also there. So we had a good session by Soru. So please try to answer these questions. Either unmute yourself and talk or put your answers in the chat box.
Hello.
Yes.
Hello. Hello.
Yes.
Good afternoon, ma'am.
Good afternoon.
Ma'am, the reason for skin excoriation could be because ileostomy, the stool consistency is mostly like it's like very saturated with the gastric juices. So this could be the reason for the skin excoriation.
Okay, thank you. Any other answers? Others, please respond.
Excuse me, ma'am.
Yes.
This patient is angry because he's like his age is like 35 years and it's like means he's in young adult age and that is one of the reason because disfigurement or like a change of your body structure is one of the reason for patient angry and upset. Hello.
Also, yeah.
Yes, ma'am. Because the age of our patient is like 35, he is middle age, and that could be one of the reason. Like in young age, it's like very embarrassing situation patient can have. and then he can be very angry and upset because of that.
Okay, thank you. Any other answers? Jay Sharma, you want to say something? Jay Sharma, are you there? So one chat answer, poor skin turgor may contribute excoriation. Okay. So you want to take up the lead?
Yeah, just looking for the answers. That's all.
Yeah, okay. So one more, the three more chat answers. Due to excoriation of skin, he must be having pain. Maybe because of his pain, he became angry and upset. And maybe the patient and family did not receive proper education on care of ostomies. Other answers. And then the patient need change feeding exposure to sun. Arabic. Okay. Okay. So due to body image, he might be angry and upset. I think Swarup, your session is effective.
I guess so. Lot of not just physical part, people are
Yeah.
touching even about the psychosocial issues even.
Yes.
It's making some sense. Nice. So here my question is, to which extent did the family and the patient was taught about the preoperative counseling, or how your lifestyle is going to be changed? Unless it is not taught to the patient and family, forget about the family for a while. So think about the patient now. So the patient was not taught about how his future is going to be. He might have a lot of things, forcefully he would have come, as a wife is forced him to undergo the surgery, and he would be upset just because of that. Generally, when you talk to few patients when they are not well, when you talk about do you want any kind of injections to undergo through, or any kind of procedures to undergo, they may say that I don't want anything to happen, just leave me alone. Many of our patients doesn't even like to eat food, but forcefully the family come forward and touch that part, where even those simple things also makes a lot of impact on the conflicts between the wife and the husband, not the families even. So it's important for us to think about it in that way even. And the change of the habits, so might be just think about the patient who is Mr. Raman, who is 35-year-old man, no? So this age group of people are like newly married. He just wanted his family to be put on in the next level, earn a lot of money, having children, and in the society he would like to have a good name and fame there. And maybe all these impacts would have contributed in making his physical appearance like more of agitated and not so happy, angry and upset about his life. This is not an old age group, right? So when you talk about this, it's important for you to think about the which category of age that the patient belongs to. So according to that, we have to go forward for. Yeah. Anything else? Anything?
Yeah, thank you. So, as Kusum said, this patient is having ileostomy. Usually, the output become through the ileostomy 500 to 1,300 ml, maybe up to 1,800 ml will be there. So, before if the patient is having ileostomy, that absorption, so loss of potassium and that sodium through the ileostomy area will be there. Then, so because of that, that higher concentration of digestive enzymes can cause the skin excoration. So this is one of the major problem. If the patient is having ileostomy, you have to keep it in mind. Maybe that patient is developing skin excoration, and the another thing is that fluid coming, the loose stools coming out from the ileostomy all the time. It's not a formed stool. And the excessive water loss. There is water. We all know also in the large intestine that a lot of water absorption is there. Here, there is a chance of the excessive water loss, and the patients will develop dehydration and renal stone. This patient is having that he came with the tiredness also. Maybe because of his dehydration and the electrolyte imbalance can cause tiredness and all. So you have to give a proper education on preventing skin excoration. If the patient is having skin excoration, we already learned how to manage skin excoration or try to apply Karaya powder on that area, scoriated area, and that way we can able to manage skin excoration. So thank you. Time up. I have one more case scenario, but not possible now. Thank you, Swarup, for the excellent presentation.
Thank you, Shiva.
Yeah, very excellent.
Thank you.
Excuse me, ma'am. Ma'am,
Yes,
excuse me.
yes,
I
yes,
had
sir.
one question, ma'am.
Yes.
Sir, you told like colonic irrigation is like we should start after 3 months. Like what is a exact some indication is there like in ascending colostomy or transverse or some descending colostomy we can do this procedure. Is there
Oh,
any
that's a
specific indication?
yeah. That's a good question. So
Yeah,
it can be
this
done. Yeah, please go ahead.
I think sort of they can read this case scenario. They'll get good idea about this. So one of you can read this case scenario.
Line on. No? Can you go through this, Shiva? I have a emergency call now. Can I take a minute?
Yeah, you can read. Okay. Thank you. So this patient, can anyone please read? Kusum, read this.
Yes,
Yeah.
yes, ma'am. Mr. T, 45-year-old male, was diagnosed with CA rectum, has undergone AP resection and sigmoid colostomy three months ago. He has been using disposable colostomy bag for bowel emptying, and he is a management executive and find it very difficult to manage it. So, what option can you advise him as a palliative doctor or as a palliative nurse?
Okay. So here this patient is having sigmoid colostomy, right? So if the when the fecal matter comes to the sigmoid colon, what type of fecal matter is there? The formed stool is there, right? Sigmoid colon. So we all know that large intestine have 4 parts: ascending colon, transverse colon, descending colon, and sigmoid colon. Okay. So when the fecal matter comes to the sigmoid colon, it will be the formed stool. Okay. So if the patient is having sigmoid colostomy, you can suggest colostomy irrigation for this patient, because here is a formed stool. You can educate the patient the importance of colostomy irrigation. If the patient is doing the colostomy irrigation, they'll all after that colostomy irrigation, the bowel will be free 6 to 8 hours. So that time they can go to the office after colostomy irrigation. There is no fecal matter will be coming out through the colostomy. So they can attach one bag, but no worry about the fecal matter coming out. So if the patient is having sigmoid colostomy, you could suggest colostomy irrigation. I hope your question is clear.
Yes, ma'am. Thank you, ma'am. Thank you so much.
Okay. Thank you.
So that means only for
Yes, Sharina.
the colostomy irrigation only for sigmoid colon
Yes.
or stoma we are doing.
Yes, sigmoid colostomy.
Okay.
And some of the patients having the ascending colostomy also, lower and ascending colostomy also, you can do colostomy irrigation, but the best patient is sigmoid colostomy. Okay, thank you.
Thank you, ma'am.
Thank you. Thank you all. I have shared the feedback link with you in your WhatsApp group also. Please go through it, and we'll see you on the next class. Bye.